Hello everybody. So I am going to do a voiceover video for chapter 11, which is just specific immune system disorders. It goes a little bit more into the immunoglobulins for our patho course. If you have any questions at the end of this, or there's something I said that you did not understand, please email me. I have no problem clarifying over email throughout the weekend to help you guys understand this information. I'm posting it today, which it's Friday. I'm doing that so you guys have a couple days to review it in case power outages or things like that over the weekend with this crazy weather. So let's get started. So we're going to touch back a little bit on innate immunity, which I think we had talked about before. Remember, innate is your first line of defense. This is composed of natural things in the body, barriers, your normal bacterial flora, your white blood cells, any protective enzymes and chemicals. Basically anything the body already has in it to just prevent microorganisms from getting in. Remember macrophages, what they are. They engulf and ingest your microorganisms and are on constant surveillance throughout the body. They are looking for anything that doesn't belong there so they can get rid of it. You also have natural killer cells, which are a type of T lymphocyte that attacks antigens. And then you have natural enzymes, bactericidal and antiviral substances, and acidic secretions that make it hard for pathogens to enter, whether this be in your mouth, your nose, anywhere that's a port of entry has some type of substance along with your cells that are there to help fight anything that's not supposed to be there. Okay, so real quick, when a foreign invader attempts to enter the system, what happens in these systems? So let's kind of talk about it. So your respiratory system, let's say you inhale a bacteria that's trying to invade your respiratory system. What does it do in response to that? First, you'll have increase in secretions, right? You start having a stuffy nose. You maybe start coughing. You're having an immune response to these invaders, right? Same thing with GI tract, with your eyes, your skin. What do you think would happen for the GI tract? You might have increased motility. You might have upset stomach, right? If certain bacteria get into the stomach, you might vomit, have upset stomach. You might have diarrhea, things like that to try to rid your body of it. What about the eyes? Your eyes might start watering. You're going to become very tearful. You might have some irritation to the area. And the skin? Would definitely be irritation, redness, maybe some warmth, right? Okay, good. All right, moving on to adaptive immunity. This allows the body to recognize an antigen before targeting it. This is your second line of defense. It develops a memory for an antigen for future reference. So we kind of talked about this last class. So again, making sure you know the difference between innate and adaptive. It has the ability to distinguish between itself and non-self. The lymphocyte is the primary cell. And there's two major categories of adaptive immunity: humoral, which is your B lymphocyte, and your cell-mediated, which is your T lymphocyte. Remember, your B lymphocyte developed in the bone marrow, uses body fluids to fight. Your cell-mediated is developed in the thymus gland, and it uses those T fighter cells to directly attack invaders. So it's a little bit more intense of an attack. But typically, your adaptive is you've experienced this before, your body remembers it, and then it targets and attacks it. All right, you also have two different really big types of cells that help with your adaptive immunity. You have the CD4 cells, also called T helper cells. They influence all other cells of the immune system, and they're involved in the cell-mediated immunity, that one that directly attacks the invaders. So really big deal, really big helper for your immune system is your CD4 cells. They talk to all the other cells. And then you have CD8 cells, also called cytotoxic T cells, and they also directly attack the antigen. There are two videos I posted that kind of help you understand the difference between innate and adaptive immunity on Canvas. All Right, so here's a really good picture I found that kind of shows you the different cells and where they are at with the innate and adaptive immunity. So you see innate, you have your macrophages, dendritic, natural killer cells, neutrophils, basophils, eosinophils, which are all a different type of white blood cell, and your mast cells. You have natural killer T cells in both, and then your adaptive has your big T cell with your CD4 and CD8, and your B cells and antibodies that you developed from having the disease before. All right, we also have active versus passive acquired immunity. So acquired immunity, remember, is you've gotten it, right? So active is obtained through exposure to the antigen or through vaccination. So this is very long lasting. You've either had the disease before, like let's say you got the flu A this season, like a lot of other people have, right? Your body has now made antibodies because of having that, and it's going to keep them for a long period of time. Or through a vaccination, like if you get the MMR, flu vaccine, COVID vaccine, things like that, it gives you a long-lasting protection for that. And then you have passive, which is pre-made, fully formed antibodies against the antigen. These are immediate and they're very short term. This is just something your body makes ahead of time, thinking it might help eventually, right? So these are pre-made, very short term. So you'd much rather active over passive because it helps you for a longer term and they're a little bit more strong. Here's another really good picture. Like I told y'all before, I'm really big on the pictures that give you active versus passive immunity. Active being the exposure or artificial vaccination to help you, and then passive is more through breast milk, possibly through IVs, your monoclonal antibodies that they can give you. They can give you artificial immunoglobulins as well to help your immune system. So often a lot of passive immunity also is given to your autoimmune, low immune population to help them get a little bit stronger with their immune system. All right, real quick, identify which type of immunity each of these are. So a flu vaccine, is that active or passive? Active, okay. Breast milk, passive. Current chickenpox infection, active. And antivenom, that's passive. Good job. All right, there's a couple different testing measures we can do for the immune system, right? We have the energy panel, which tests for immunocompetence, okay? So immunocompetence, basically we're looking to see how the body reacts to small amounts of antigens. Does your body have a good immune system or not? That's what this is testing. You have an antibody screening, which is lab test to confirm adequate immune protection against a particular antigen. So they're measuring the immunoglobulins within the body, especially IgM and IgG. So when you see an antibody screen, they do this for rubella. We want to see, is the body reacting to the rubella that or is it not? And that's kind of how we're testing to see if antibodies already exist against something or not. Typically, it means that they will give that vaccination. For example, we do a rubella titer on every person that is pregnant, and if it has a certain reaction, we offer them the MMR vaccine because their body is no longer really protected against rubella. And then you have allergy testing, which is the picture shown on the screen. Can be skin tests, can be blood tests, measuring the body's IgE reaction, which we had talked about. Remember, IgE is all about allergies. So typically they do the skin tests like the picture shown, where you're trying to see what they have a reaction to, which this person's had a reaction to almost all of them. Poor guy. But you want to see the body's reaction to that. You have to remember when you're doing these tests that you want to have some education involved, right? So, for example, if they're getting an allergy test, we maybe want to say don't take any antihistamines for 24 hours before, because antihistamines do what? They block the histamine. You don't have that reaction. But if you're doing an allergy test to see what you're allergic to, you want that reaction to happen, right? So that you can actually see what you're allergic to. Yeah, so no antihistamines before your allergy testing and your allergy testing. All right, let's get into the different hypersensitivity reactions. There's 4 different types. Type 1 is immediate, type 2 is cytotoxic, type 3 is immune complex, and type 4 is delayed. So this could be excessive or inappropriate activation of our immune system. Hypersensitivity. We're too sensitive. Our immune system is too responsive, right? So the body is damaged by the overactive immune response rather than the antigen itself. The body is being more damaged from itself than it is from the bad thing happening. It's either cell-mediated or antibody-mediated immune mechanisms that are happening, but regardless, we need to know what type it is and we need to try to stop it or delay it if we can. All 4 types of these can be very hurtful to the body itself. Okay, this is a really good picture I found, yet another, of all the hypersensitivity reactions, type 1, 2, 3, and 4, that kind of tell you what's going to be causing it, what's going to be going on. But we're going to get into each of them. All right, type 1, immediate. What does that mean? It elicits an immediate, rapid response from the immune system. Okay, binds to mast cells common in the respiratory tract, nasal, and conjunctiva. So this is where you're most likely going to see your hypersensitivity at, the respiratory tract, nasal, and conjunctiva. Some allergens that are typically causing in this type 1 is dust, pollen, foods, and dander, which has a really large allergy to most people. And you'll definitely see the difference between a regular allergy of, oh, I'm just a little stuffy because there's dust in the air, to this immediate hypersensitivity, right? It's an intense histamine reaction, allergic reaction. And this is where anaphylaxis can happen. Widespread edema, difficulty breathing, because remember, this is going to be the mast cells in the respiratory tract and the nasal tract, right? So all that swelling is going to happen there. It's going to make it difficult to breathe, and they might have vascular shock due to sudden vasodilation. So what other allergens do you think could be in this category? What are some common allergens for anaphylaxis? Peanut allergy, bee stings, right? Mosquitoes, seafood. Good. So I want you to remember type 1 is going to primarily have to do with the respiratory tract, nasal tract, and conjunctiva, and this is typically where the anaphylactic allergies come from. Moving on. Type 2, that's your cytotoxic hypersensitivity. This is very tissue-specific cytotoxic. IgG or IgM antibodies attack antigen on host cells, leading to cell destruction, dysfunction, or damage. These are your blood transfusion reactions, hemolytic disease, and certain drug reactions. Autoimmune hemolytic anemia, like hemolytic disease. These are antibodies that target red blood cells. Rheumatic fever is another example. Antibodies target heart tissue after a strep infection. Myasthenia gravis is another example. Antibodies block acetylcholine receptors at neuromuscular junctions. Graves' disease, antibodies stimulate the thyroid gland. These are just all examples, okay? Drugs like penicillin sometimes cause these type of reactions. Any type of management of this would be corticosteroid use or other immunosuppressants. We need to get that immune system to relax, to calm down for this to stop happening, to stop the injury from happening. Type 3 is the immune complex hypersensitivity. This occurs when antibodies bind to circulating antigens, forming immune complexes that deposit in tissues, activating complement and causing inflammation, tissue damage, and conditions like lupus, rheumatoid arthritis, serum sickness, and vasculitis. So type 3 has a lot to do with inflammation in the tissues themselves, right? So arthritis, lupus, we're going to get into some of these things in a little while, examples of such. But remember, so let's start back from type 1. We're looking at anaphylactic response, closing of the airway, right? Type 2 is cytotoxic. This is certain drugs and your blood transfusions. Type 3 is immune complex. We're looking at severe inflammation in specific tissues such as joints, arthritis, lupus, vasculitis. Type 4 is your delayed hypersensitivity, a cell-mediated immune response involving T cells, not antibodies, that cause inflammation and tissue damage hours to days after exposure to an antigen. So this is often seen with skin conditions such as poison ivy, your TB skin test, which is why you have to come back days later to have it read, right? Because it's going to take time to respond. Organs transplant rejection, this can take many weeks, months. I've even seen one a year or two out. They're going to be on anti-rejection medication for a long time to prevent this from happening. And your type 1 diabetics, they have a very intense immune response as well. So remember, if you see any type of allergic reaction or inflammation response happen days later, it's typically going to be your type 4 because it's the delayed hypersensitivity. All right, autoimmune disease. In these diseases, T cells cannot distinguish between the self and the foreign cells. This is why the body will start to attack itself in autoimmune, because auto is self. This leads to attacking the body's own tissues, cells, and organs. The body will develop antibodies to attack its own cells. And I have a picture here of where these things typically occur. You see it a lot in joints, very, very often in joints. Muscles, skin, blood vessels, digestive system, endocrine system, such as the thyroid, and the nervous system. So first, we're going to talk about systemic lupus erythematosus, or SLE. This is a chronic disorder characterized by autoantibodies, like we just talked about. So it has autoantibodies that attack its own system, right? Most of these autoimmune disorders have remissions and exacerbations. So remissions means they're not feeling anything. They're not feeling any abnormalities. They're back to normal. Exacerbations means it's like a flare-up. It's getting worse. They have a period of time where it's really bad. These exacerbations with lupus are typically fever, skin rash, joint inflammation, damage to the kidneys and lungs, and serosal membranes. Okay, mainly this happens in women of childbearing age. African American women are 2 times more likely to develop, and they don't know why it's happening. Risk factors, typically lupus is genetic. It could be hormonal, environmental, or it can be due to many medications. Most often than not, I've seen genetic and environmental. Antibodies form immune complexes that are deposited in organs and tissues of the body, and their signs and symptoms are the butterfly rash. This is very, very common. The butterfly rash is a rash, a very red rash on the tops of the cheeks and across the bridge of the nose. Okay, kind of looks like a butterfly. They could have nephrotic syndrome, which is issues with their kidneys, and Raynaud's phenomenon, which is where their typical hands, fingers will turn very, very, very white. They'll have numb. They'll have no feeling in it. It'll be painful. And typically this happens like when their hands get cold. The diagnosis of lupus is often missed, unfortunately, but the criteria is based on a combination of clinical findings. To touch a little bit more on nephrotic syndrome, like I said, it's with your kidneys. With nephrotic syndrome, there's a lot of protein in the urine. Basically, the kidneys become very poor filters and they filter out all the things that the body needs. So the filters become very large, allowing really big things to pass like proteins and things like that. So you can test this in a urine sample. This is a good picture of the butterfly rash and Raynaud's phenomenon. And this other picture kind of shows the different symptoms, the different things that can happen with it. This is including fever, fatigue, chest pain, achy joints, that butterfly-shaped rash I had talked about. They can get mouth ulcers. They're going to have some kidney issues, like I had talked about with the nephrotic syndrome. They could have weight loss, other skin rashes, and swollen ankles. And you have to remember, with the complications that come with like the kidney disease and things like that, now you're having more symptoms than just the symptoms of lupus, right? You're now having symptoms of nephrotic syndrome on top of everything else. So sometimes it can become a little bit cloudy because now they're dealing with other comorbidities that are caused from the lupus. So they're going to have more symptoms as well. All right, moving on to rheumatoid arthritis, RA. This picture is very typical for someone with rheumatoid arthritis. This is a chronic autoimmune disease, 2 to 3 times more common in women. They really don't know why it happens, but they bet most of it is from genetic factors. The body's immune system attacks its own synovial fluid, which is the joint fluid, so that's why you see it specifically in these joint areas. It stimulates inflammation and destruction of cartilage, bone, tendon, and ligaments. It can be very, very painful because basically all these bones are going to be grinding together in all these joints because of the joint destruction that's happening in the area. T cells play a key role in the destruction of the joint component. And you know those T cells are very strong destroyers in your body that are meant to destroy foreign material. But in this case, it's destroying its own cartilage and tendons and all those things, making it very hard to move these joints. A lot of people with this type of arthritis have very stiff fingers. A lot of joints, they really just can't move once it gets past a certain point. It becomes super painful, and they do have flare-ups just like they would in any other. So classic symptoms, symmetrical, tender, swollen joints, typically in the fingers, wrists, knees, hips, and feet. I would say fingers is definitely the most common and most easily seen from a distance, right? I mean, look at this picture. So they have the boutonniere deformity of the thumb, which shows in that picture, ulnar deviation of the metacarpal joints, and swan neck deformity of the fingers. You can see how different these joints look from a regular hand, right? So you can see the characteristic deformities. I would make sure you know what these are. If you see swan neck deformity, that you know what that looks like and what it's associated with. Diagnosis depends on what they see, right? It's based off of clinical criteria. They're going to have really elevated inflammation markers that we had talked about before, okay? And an x-ray. Oh, and just to iterate, because I'm not sure if I did, RF is rheumatoid factor. It's an autoantibody protein produced by the immune system. Basically, it's the protein that starts attacking its own tissue. So if they have that in their system, then they kind of can deduce that they have an autoimmune disorder. And then when they see hands and feet and wrists that look like this, then they know, okay, it's probably rheumatoid arthritis. And you should know with the other ones. All right, sarcoidosis. This is characterized by an accumulation of T lymphocytes and macrophages in various organs. This can be any organ involved, but it's commonly the lungs, skin, eyes, liver, and lymph nodes. Primarily in females, and African Americans have a higher risk. It presents with very general symptoms: fever, fatigue, malaise, anorexia, and weight loss. And it's going to depend on the organ that is being attacked. So basically, you remember macrophages engulf and destroy tissue, and T lymphocytes also attack. So it can choose any organ to start attacking, and you can assume you're going to start having symptoms of whatever area is attacked. For example, if the lungs are being attacked, we might start having oxygenation issues, chest pain, circulation issues, things like that. Skin, you'll probably actually start to see the breakdown. Eyes, we might start having issues with vision. Liver, you might start having jaundice issues with breaking down of waste. And lymph nodes, you'll probably see a lot of swelling, inflammation, and pain in all of the lymphatic areas that we had talked about last class. Diagnosis is going to be based on the clinical presentation, tissue samples of whatever area is being affected, and exclusion of any other disease. Typically, that's why autoimmune diseases are so hard to diagnose. It's because there's many different disease processes that can mimic an autoimmune disease, and unless they can't find anything else is when they get to autoimmune. So it takes a while sometimes to diagnose these diseases because they have so much other diseases to exclude out of the scenario. All right, here's some pictures I found for sarcoidosis. Shortness of breath, persistent cough would be perfect for the lungs being attacked. Red bumps or patches on the skin, that fever, fatigue, and weight loss, red or sore eyes, vision changes, swollen lymph nodes, joint or bone pain. Okay, kind of everything I had said on the previous slide. And then here's another picture that kind of shows you the different areas that can be affected by this autoimmune disease. All right, next we have Sjogren's syndrome, other called SS. This is characterized by dry eyes and dry mouth. Basically, this is cell destruction of the salivary and lacrimal glands. So the autoimmune disease focuses on these specific glands and attacking its own tissue. Primarily seen in women 50 to 60 years old. Clinical presentation, fatigue and malaise can be with just about any autoimmune disease, along with fibromyalgia, dry mouth, dry skin, blurred vision with burning and itching eyes, and of course enlarged lymph nodes because of all that inflammation. To clarify, fibromyalgia is a chronic condition, typically really focuses on body pain, fatigue, sleep problems. It's just a really intense body pain with heightened pain sensitivity. Typically, it's genetic unless it's associated with one of these autoimmune diseases. How it's diagnosed is going to be based on clinical presentation and antibody screening to see if it's autoimmune. But because some of these symptoms are typical for people that are as they age, such as the dry eyes and dry skin. So you have to make sure it's autoimmune. Right, scleroderma, aka systemic sclerosis. This is another chronic autoimmune disorder. They don't really know where it came from, but it's characterized by abnormal accumulation of fibrous tissue in the skin and organs. Skin is most notably affected. Also can be found in the GI tract, kidneys, muscles, and lungs. Typically in women 30 to 50, African Americans are most commonly affected. Really, with all the fibrous tissue, it just leads to really, really tight skin. It can cause scarring on the internal organs and blood vessels, causing joint stiffness. You have Raynaud's phenomenon, fatigue, digestive system issues. You just think like if you're having all this fibrous tissue that's not supposed to be there, in the GI tract, you can start having motility issues, severe constipation. They're not doing what they're supposed to do. It makes the organs not function correctly, and everything really becomes stiff. If this happens to the lungs, do you think they can take really deep breaths? Probably not. Because of all that fibrous tissue, it's not as pliable. It's an inflammatory reaction with injury to the endothelial lining of blood vessels as well. that extreme collagen occurs that I told you about, and that extreme fibrosis of the skin and those deep tissues. Any complications are going to arise with whatever organs affected, including kidneys, heart, whatever vessels are applied, and they're going to have a lot of pain and swelling in their musculoskeletal system, and they're at higher risk for an MI, which is a heart attack, because of that fibrotic tissue. The heart can't pump as it should, and you're also blocking off a lot of those vessels, causing ischemia, which is lack of oxygen to the area, which is in turn what a heart attack is. They diagnose it based on the clinical presentation, x-rays, and an EKG. They are going to present with what we call CREST syndrome, which is on the next slide. All right, so this is an example of that thick, waxy skin that comes with that fibrotic tissue. And then CREST syndrome, it's for the acronym CREST. C is for calcinosis, which is the calcium deposits on the skin. Raynaud's phenomenon, which we had talked about. Esophageal dysfunction, which would be acid reflux. And decreased motility, like I had said. Sclerodactyl, thickening and tightening of the skin on the fingers and hands, making it harder to move. And then they might have dilation of the capillaries, causing red marks on the surface of the skin. Okay, going into immunodeficiency disorders, you can have primary, which would be genetic, typically manifests between 6 months to 2 years of age. X-linked disorders are mostly manifested in males, and they could have B-cell deficiency is more common than T-cell. They don't, like I said, they don't really know exactly why it's happening. It's just genetic factors. IgA deficiency is the most common. And then secondary immunodeficiency is acquired, which your biggest one would be HIV. All right, getting into the genetic one would be severe combined immunodeficiency disease, SCID. It's a genetically distinct syndrome, defects of both antibody-mediated and cell-mediated immune response. So they have a malfunction of T cells and B cells, and it typically affects infants at 3 months of age is when you'll start to see a lot of these issues, susceptible to recurrent infection. So this is a prime example of like the Boy in the Bubble type movie, where their immune system really doesn't exist. They don't have anything in their body that's going to help them fight off any type of infection, leading to constant recurrent infections, severe infections, risk of death from the amount of sickness that their bodies are taking on at all times. Then you have selective IgA deficiency, most common primary immune deficiency in your genetic primary disorder. Genetic cause 50 times more likely from a first degree relative. Cells that produce IgA are dysfunctional, so they just don't have IgA really antibody in their body. Signs and symptoms are recurrent sinus and pulmonary infections, common in adults, severe ear infections, constant sinus infections in children. Hypogammaglobulinemia, what a word, is another one of your primary immunodeficiencies. Decreased number of Igs related to a defect in B cell development and maturation. So they're just not making immunoglobulins, all of them, as they should. It can be genetic or acquired, but it just makes people more susceptible to infections. Your immunoglobulins are there to help protect you, right? But they're just not, none of them are there with this type of disease, leading to more ear infections, sinus infections, bronchitis, pneumonia, stomach flu, meningitis, skin infections, really any type of infection they're more likely to have because their immune system just isn't doing what it's supposed to do. All right, patho pit stop. What significant role does immunodeficiency have on an individual? And what is the first clinical clue indication of a primary immunodeficiency disease in children? So the first one, right, I mean, significant role, if they don't have any type of immune system, they're more likely to have really dire infections. Maybe an infection that, like a little sinus infection, that to a normal person, they would be able to kick no problem. They're going to have possibly severe illness from this if they don't have an immune system responding how it should. And then in children, the recurring sinus infection, bronchitis, constant coughing, nasal congestion, ear infections are going to be some of your first signs that they just aren't they aren't fighting off pathogens as they should. All right, moving on to acquired, you have HIV infection. So remember, there's 3 major stages of HIV infection. There's acute, chronic, and then we progress to AIDS. So a retrovirus is what this is considered, as a very long latency period and a slow progression. So sometimes people can be infected with HIV and not show any signs or symptoms until a later period, and is slow to progress. Seen often in African American and Hispanic men and your IV drug users. HIV is notorious for completely depleting the CD4 cells, your T cells that fight alpha infection, right? So they become severely immunocompromised as the HIV progresses. Complications are going to be any opportunistic infections that can make their way into the body. So how do we diagnose it? Well, we look at their CD4 count, because if that's what HIV attacks, then their CD4 count will probably be severely low. We want to look at their viral load, which, if you remember, viral load is going to be how intense the virus already is in the body. So the higher the viral load, the worse the infection is. And you can do HIV drug-resistant testing as well. Remember, a retrovirus uses an RNA sequence, so it's using genetic material once it's inside the host, and infects and makes new DNA material with the host cells. That's what a retrovirus is. That's why HIV is severely, it's a severe infection and affects a lot of the population. Okay, so moving on to the pictures, we have how it affects the body. You kind of have mouth sores, fatigue, sore throat, diarrhea, night sweats, muscle aches, rash, fever, chills, swollen lymph nodes. Typically, severe fatigue and sores are some of the signs that people start to get really concerned about. And I also included a picture on how it can be transmitted, whether that be syringes that are not clean. It can be transmitted through pregnancy and breastfeeding. There's a large fear of it being transmitted through blood transfusions. However, that percentage has went down drastically over time. Organ transplant, unprotected sex, and it's not transmitted through food, drink, or utensils, insect bites, kissing or touching, clothes or towels, or toilets or showers. There was a lot of miscommunication back in the 80s and 90s over HIV and how people got it. So there's a lot of flyers out there now that show just how it can be spread from person to person. Okay, last but not least, okay, so let's think. So you have a young woman who's pregnant with HIV, asks you if her unborn baby will have HIV too. What should you tell the patient? So it can be spread through pregnancy, right? Because there's a lot of blood that is transferred around that the baby can get infected. To prevent the spread of HIV to the infant, you have to start ART therapy, which is antiretroviral therapy, early. And basically, it kind of helps keep the viral load undetectable in the baby, which is the amount of HIV in the blood, right? Essentially. When the baby is born, its initial antibody test is positive for HIV. What does this mean? Does this mean the baby's infected? So, in order to not have HIV permanently, the baby needs to start HIV medication as soon as possible, within 6 to 12 hours of birth, basically as soon as possible. And they need to be on that medication for 4 to 6 weeks to prevent the virus from establishing itself. So yes, the antibody test may be positive, but until that viral load goes up, we can do something about it in these newborns. So you have to do a lot of education on how to ensure that this does not that it doesn't establish itself in the newborn. All right, so that is it for chapter 11. I was going to have a little review activity that we may have time for sometime this week for the 3 chapters I covered for exam 1. If you have any questions on this content, just feel free to email me, and y'all have a great weekend.